There are many fertility centers that are providing care to patients with endometriosis. And sometimes you hear crazy things like endo doesn't matter. And then when it doesn't work, they tell you, well, it was because of your endo. So we decided to create the definitive endometriosis presentation for you so that you'll understand how it impacts your fertility, how it doesn't impact your fertility, and what protocols and treatments are right for you. I'm Dr. Rahi Victory, a fertility specialist, double board certified in Canada and the US. Join us to learn all about your endo. So we're going to chat about everything we can for endometriosis. And the place to start is, what is endometriosis? Endometriosis is the presence of endometrial stroma or glands outside of your uterus. Way too technical. So in layman's terms, it's when the stuff that comes out with your period actually ends up outside of the uterus. It can be on the uterus, on your fallopian tubes, your ovaries, anywhere in your pelvis, and sometimes even distant sites, your umbilical region, your diaphragm, in the heart, in the brain. There are all sorts of kind of weird and strange locations to find endometriosis in. Is endometriosis changing over time? It actually is. We know that over the years, we have been seeing an increasing prevalence of endometriosis with almost a 40 to 50% change and an increase from studies that were done prior to 2000 compared to studies done after 2000. What this means for you is the age is very important because as time passes, we're seeing an increased prevalence of endometriosis, meaning more and more women are becoming at risk. We don't quite know why yet, but we do know that this trend is a positive trend and it is very statistically significant. What are the risk factors for endometriosis? Well, there are many. Some can be things like genetics. We know patients with certain receptors to estrogen can have different levels of endometriosis. We know that there can be inflammation markers that predispose you to endometriosis, including things like tumor necrosis alpha and interleukins. We know that there can be dietary factors that can contribute to that, including the fact that dairy is protective. Many people have heard they should stop dairy when they are experiencing infertility. Simply not the case when you have endometriosis. Things like red meat and alcohol are detrimental. So those are factors that are critical. And then we know that the environment is also critical. Things like BPAs, plastics, even things like makeup can increase the risk of endometriosis. What about all the things you didn't want to know? There are some bad aspects of endometriosis, and it's important people be aware of these because it has a significant impact on multiple different areas of your health. We know that psychosocially, patients with endometriosis have a lower quality of life. There is equal or lower quality of life than even other chronic conditions like diabetes, heart disease, breast cancer even. So it has a very negative impact on how you function on a day-to-day basis. And again, it's critical that as physicians, we pay attention to your condition because if we're missing endo, it can have a huge ripple effect on how many different aspects of your health are dealt with or addressed. So it's critical you get diagnosed and you get treated in order to minimize the symptoms, because when we actually treat you, you can improve the quality of life. And that is critically important for all those women that are suffering. Heart disease has also been studied in relation to endometriosis. We do know that major cardiovascular events, including cardiovascular insults like heart attack, things like stroke, peripheral vascular disease, and major adverse cardiovascular events can all be increased when you have endometriosis. Not something that is commonly known. Very few people are even talking about this, but this is, again, another reason to address the endometriosis and treat it, because there are protective benefits to addressing endometriosis if we catch it early and deal with it before it becomes a major health risk for you. What about preeclampsia? Also tightly involved with endometriosis and heart disease. There is an increased risk of preeclampsia in women that have endometriosis. So simply getting pregnant does not solve all of the risks from endo, and we'll talk about some other ones shortly. But once you are pregnant and you're far along in the pregnancy and everything is going well, you are still at an increased risk of approximately almost 50% for developing preeclampsia, a very significant number. And again, a reason to pay close attention to the protocol that the patients are using and their care during their pregnancy. It doesn't just end when we get them pregnant. We're responsible for you for the whole pregnancy. Thankfully, there's no increased risk of cesarean section or postpartum hemorrhage, but there are significant risks for patients with regards to preeclampsia, and that needs to be monitored closely. What about alcohol? Well, as I mentioned earlier, alcohol is a significant increase in risk. It's a 15% increase in risk of having endometriosis, as high as 22% when you're a significant alcohol consumer. So minimal doesn't seem to be quite significant. It was just borderline for significance. But if you're a moderate drinker, you have a significant increase in your risk of developing endo. So what you do with your social habits can actually play a role in your risk of developing endometriosis and how the endometriosis impacts you. What about cancer? There are increased risks of cancer for patients with endometriosis. Now, before you all panic, thankfully, the risks are very low. The risks include things like endometrial cancer and ovarian cancer, but it's a very, very rare form that I've actually only seen once in my career. So there is a very substantial increase in risk. It's almost 250% higher, but it's a cancer that's so rare, 250% is still going to mean a very low risk overall. But it does mean you need to be vigilant and your doctor needs to be vigilant. So we make sure we are taking appropriate care of you again and making sure that we are not missing any symptoms or signs that could contribute to not just a cyst of endometriosis, but actually something a little more concerning going on there. Thyroid cancer is slightly increased. Breast cancer is slightly increased, but it is a very, very small increase. There is no increase in colon cancer. And strangely, melanoma was studied as well and was not found to be significant. So that's all very positive in the sense that we have minimal risks, but there are increases in those risks. The actual number of people affected is very small, but we do need to take each patient as an individual and make sure that each individual is getting appropriate care. Does endometriosis impact infertility or fertility? And a lot of physicians are telling their patients, no, it doesn't. Just came back from a show in the UK where we heard from many patients that their physicians told them, don't worry, if you're doing IVF, endometriosis doesn't matter. The truth? That's total nonsense. Endometriosis matters. So it is critical to make sure that you are addressing your endometriosis as you go through your fertility care. How does endometriosis impact things? Well, first and foremost, there's mechanical obstruction. As you can see in this image, the whole pelvis is stuck together. The ovaries are stuck, the fallopian tubes are damaged, there's adhesions, there's inflammatory vesicles and structures there. And so it is very important to understand there can just be a physical blockage of how things are supposed to work. Number two, it significantly impacts egg quality. There's dysregulation of steroids inside the eggs. There's an altered environment inside of the eggs in terms of the physiology of the eggs. The shape and the quality of the eggs can be hampered as well. Even the mitochondria, which is the energy source of the egg, can be altered. And you actually get fewer eggs from endometriosis patients and a higher number of immature eggs, which again is something you have to factor in when you're doing a stimulation protocol for those patients. The AMH level is lower in patients that have endometriosis. And we frequently get a big, long discussion of, well, I have a cyst of endometriosis called an endometrioma. What do I do? Because the physicians are telling patients, don't touch the cyst, you're going to weaken your ovaries. Well, they're missing a little bit of information there. So we do know that in patients that have endometriomas and they have them removed, the level of AMH does go down. So your AMH level, which is the best marker of how strong your ovaries are that we have so far, will decrease somewhere between 30 to 50%, as you can see in this chart that we've put up, when you have an endometrioma present, the cysts of endometriosis. Interestingly, they did not see a statistically significant decrease in the number of eggs that they counted, but the ovarian reserve testing is showing a decrease. What's important about this? Well, if you just have the cyst of endometriosis, so you haven't even touched it, it's just sitting there, no surgery performed, you still have almost a 40% decrease in your AMH. So this is very much a damned if you do, damned if you don't situation. If you leave the endometrioma there, it's damaging your AMH, it is reducing your ovarian reserve. And if you take the endometrioma out, then it can also reduce your ovarian reserve. So this is very, very important for people to consider. And we'll come back to that in a few minutes because there's a critical element in there that has to do with the quality of your surgeon. So I want you to keep that in the back of your minds as you watch the rest of this. What about the endometrium itself? The endometrium is highly impacted by endometriosis. And we know this from a really great study where they looked at patients that had endometriosis and compared the ones that used their own eggs versus the ones that used donor eggs, and they compared that to another group where there was no endometriosis. And they showed that even when you were using donor eggs, so there's no impact from the patient's egg quality issues with endometriosis, they did have a very significant, almost 50% decrease in the actual implantation and live birth rates from the patients that had endometriosis compared to those that didn't. So we're all donor eggs, shouldn't have any impact from the endo, but it has to do with the ability of the embryo created to implant in the uterus. And so the belief is there is a direct impact from the endometrium. And if you can see the graph or the picture that's shown there, you can see there are millions and millions of little processes going on that allow your embryo to implant. Endometriosis interferes with a large number of those processes, creating an inflammatory environment that is unfriendly to the embryo. Which leads us to the last point here, and that is that endo significantly impacts inflammation in the body. Endo has a tremendous impact on cytokines and inflammatory markers, things like interleukins, TNF alpha, TGF beta 1. All of these are markers that increase the inflammatory response in your body. Anytime there's a lot of inflammation, it's not a super happy environment for your embryo, and embryos can be attacked by an overaggressive immune system, which is trying really hard to actually get rid of the endometriosis, but doesn't discriminate between an endometriotic cell and an embryo, and it ends up terminating the embryo sometimes too. Even looking at studies comparing women with, for example, tubal factor disease compared to women with endo, you do see significant increases in all of those inflammatory markers. So we know this is endo-specific problems. What kind of further risks are there from endometriosis? Well, unfortunately, it does increase your risk of miscarriage. So when they looked at this in women who spontaneously conceived, there is an increased risk of miscarriage. In women with endometriosis, their miscarriage risk was similar when they were doing assisted reproductive technology to the risk of women with tubal factor infertility. Things like antepartum hemorrhage, which is bleeding in your first trimester, some suggestions of postpartum hemorrhage, although that was previously shown to be okay. Preterm birth, stillbirth, and placenta previa have in many studies been shown to all be increased in patients that have endo. So again, once you're pregnant, it doesn't necessarily mean smooth sailing. You still have to be, vigilant and careful to make sure that you are getting appropriate care so that you don't risk yourself or your baby throughout the pregnancy. And on top of that, there does appear to be an increased risk of aneuploidy, meaning genetically abnormal embryos in patients with endometriosis. So in one study where they looked at 625 patients who underwent pre-implantation genetic testing, the aneuploidy rates in the group that had endometriosis was higher than in the group that did not. And that's actually being shown in several other studies as well. So it does seem to hold that patients with endo have higher rates of genetically abnormal embryos. Why, you're all asking? We don't know yet. But maybe it has to do with the inflammation, reactive oxygen species impact on the DNA within the cells. We don't know, but we do know that it appears to have a significant impact. So if you're calculating your risks, if you're watching our embryo math video to calculate how many chances or times you'll need to do IVF, make sure you factor in that if you have endometriosis, you need even more than what we're showing in that video. Well, some people were told that it doesn't matter if you have a euploid embryo. If it's already genetically normal, there's no difference. And they're citing this study from Bishop et al., printed in Fertility and Sterility, that you can see there, where they showed that there was no difference. So they said there's no difference in outcomes if you had a genetically normal embryo between the patients with and without endometriosis. But there are a whole bunch of problems with this study. And those problems are, there is no scoring of the degree or severity of the endometriosis. It's not mentioned anywhere in the study. They don't say if they're severe or if they're mild, no idea. Number two, there was no confirmation of endo pathologically. So they said that they had laparoscopy to see if there was endo, but they didn't confirm it with actually taking biopsies and sending it off. So we don't actually know if some patients did or did not have endometriosis. The next part, the control group wasn't screened for endometriosis. So the group that they're comparing it to didn't undergo laparoscopy. We don't know if they did or did not have endo. And if they did have endo, you'd see a lowering of the overall success rate, which would end up causing everything to be kind of unbalanced and an unfair comparison. It's also a super selected group of patients. They had low BMI, very low age, and kind of absurdly high success rates, almost abnormally high success rates. It's hard to apply this to a general population. They did state that the endometriosis patients did take more cycles to achieve the right number of embryos to be able to transfer. So that's another factor that they kind of grazed by. And again, in this study, they said there was a higher rate of genetically abnormal embryos in the patients with endometriosis. So another factor that's important to consider as you move forward. So it does matter. Well, what kind of diagnostic tests do you need? So there is a huge slew of diagnostic tests available, looking at things like ultrasound, looking at things like MRI, and various tests that can be done. The truth is, there are now a lot of different places saying that they have advanced endometriosis screening ultrasounds or MRIs to be able to detect it. The reality, it's not that sensitive or specific, and we are never going to replace the gold standard test of endometriosis, which is to do laparoscopy with an actual biopsy to confirm pathologically that there is endometriosis there. So that's very important for everyone to realize. There are places that are telling you they can detect your endometriosis via, MRI or ultrasound. They might be able to, but you can't find superficial endo that way. You cannot find anything other than cysts of endo, which you can see with a common ultrasound transvaginally, or deep infiltrating endometriosis, and possibly adhesions, but then you're not always going to know if those adhesions are due to endo or due to some other action or activity or pathology that's going on in the pelvis. What about Receptiva DX? Well, I surfed the internet and I looked at Receptiva DX. And Receptiva DX has this wonderful webpage. And if you scroll down to the bottom, which you can see me doing here, it says very clearly that they have this super high rate of detection, somewhere around 93, 94%, and it costs about $750, which is fabulous, right? Like, hey, I can just take this blood test. They're going to measure this protein called BCL6. And from that, they can tell you, do you have endometriosis or do you not have endometriosis? Except there's a great study done in Nature, a huge scientific journal, and this was scientific reports from Nature. And they looked at a simple questionnaire with, I think, 20 or 30 questions in it, and they had the exact same ability to detect if you have endometriosis or not. So you don't need to pay the folks over at Receptiva, the very nice folks, $750, because you can figure out if you have endo with the exact same precision from answering a bunch of questions. No testing needed, no blood test needed, very, very simple and straightforward. And Receptiva DX has not actually ever been proven to improve the outcomes once you know you have it. So it's not necessarily the test that everyone is hoping it to be. It is a reasonable, rational test, but do I recommend it to my patients? Never, because I can figure it out without doing that and save my patients $750. So you have to be asking, why are we doing Receptiva if they're offering it to you? What kind of treatments are available for endo? Well, you can do nothing. So when you do nothing, you have your standard rate, which in many cases is zero because you've probably been trying for years and it's not working. That's not to say all patients with endo are infertile. Not true at all. There are many patients with endometriosis who are able to conceive, sometimes even without a lot of difficulty. But in many patients, it is a problem. Once you start trying naturally, the rate is somewhere between 2 to 10% based on studies, and that's per month of trying. If you upgrade that to something like injections and IUI, you can go from about a 2% rate at baseline in one very old study that was done to as high as about an 11% success rate. Now, this is very old data, and newer scientific studies would probably support a higher rate, but there are actually no really good studies in endo patients looking at just doing IUI, because the minute you walk through the door, the first thing they tell you is you need IVF. So we don't know the stats these days on IUI, but it does seem to be much higher than what you can achieve naturally. What about IVF? Well, there's only one study actually directly looking at doing nothing compared to doing IVF. And it's a very old study done by a Canadian physician. And in that study, they actually showed about a 40% success rate. Now, we would all, hopefully, be very disappointed in only achieving a 40% success rate. But compared to the reference, which was doing nothing, this was a much higher success rate. It was 40% higher than what they were getting in the reference. So it's a reasonable success rate, but it's not a great number overall. We would certainly want something much better if we were trying these days. And then laparoscopy. Laparoscopy can actually be incredibly useful. There is between a 63 to 83% increase in your chances of getting pregnant if you have laparoscopic treatment. Why isn't that being offered? A variety of different, unfortunately, poor reasons, including the fact that your fertility center is trying to get you pregnant as quickly as possible, and they're pushing people into IVF. There are technical reasons for that. There are, efficiency reasons for that. And sometimes, unfortunately, there are financial reasons for that, because fertility clinics don't make money when they're doing laparoscopy on you, but they do make a lot of money when they're doing IVF on you. So make sure you know your options. You have to know that you have multiple options: natural, IUI, IVF, and laparoscopy. All of those should be presented to every patient. No one should be railroaded into just doing one treatment. That's neither fair nor appropriate. And you should be offered all of the options with a clear explanation about what that option is, what the chances are with that option, what are your risks, what are your benefits. Okay, what about removing your endometriomas? So you have endometriosis, you want to know, should I get it taken out or shouldn't I get it taken out? It's the big question, because fertility centers don't like telling you to take out your endometriomas. They're all terrified of the impact. Well, we know it's going to lower your AMH. I showed you that earlier. And we know that at the same time, it's not actually lowering the number of eggs that are there. So that's an important factor to consider. Yes, your ovarian reserve will go down, but the number of eggs you have available is going to stay the same. Some people have proposed a size threshold. Operate if it's more than 4 centimeters, don't if it's less. I actually find that to be a pretty reasonable assertion, because when they're bigger than 4 centimeters, they're starting to really damage the ovary. Does it improve live birth? It does improve live birth. From the Cochrane database, where they do these big meta-analyses and systematic reviews, they said there is moderate quality evidence that laparoscopic surgery improves viable pregnancy outcomes in patients that have endometriosis and endometriomas. So you should not be afraid to go for surgery, because it actually is going to result in a better outcome for you. And many, many people are not being told that. They're just being pushed into more and more IVF. And when it doesn't work, they go, oh, well, it's your endo, just try again. Never just try again. Always make sure you're getting the right information and right answers, and make sure you know what your options are, because laparoscopy can help you. Now, it is important to differentiate between a good laparoscopic surgery and a not good laparoscopic surgery. So I'm going to show you 2 videos here. In the first video, at the beginning, you're actually going to see that the surgeon is first doing an appendectomy. They're going to actually remove the appendix. And then once they've removed the appendix, they're actually going to start taking the ovary. And you can see the ovary has a bit of a cystic appearance to it. They pop the ovary, there's a whole bunch of brown fluid that comes out under pressure, and then they take off basically the top 1/3 of the ovary and remove it. This is called deroofing the ovary, because you're removing the top part of the ovary off. All you did was remove 1/3 of the available eggs. That is a disaster scenario, and nobody should be doing that. What you can see in this other video, which is quite clear, is they make a very careful incision. They very carefully open up the ovary, and then they peel the cyst out, and then they take great care at the end to actually repair the ovary and put it back together, which you don't actually have to do, but they did in this study or this video. And it's critical to understand that that actually is the right way to do it, because you're doing a minimum amount of damage to the ovary. You're making one little tiny cut. You open the ovary up very carefully. You peel out the cyst very gently. You're not losing any ovarian tissue, and you're putting the ovary back together. You're not compromising the blood supply. You're not compromising the function. You're not burning the ovary all over the place to stop any bleeding, which is a big no-no. And these ovaries actually are going to respond much, much better. I know this because this is the way I do it. And we don't have that much of a drastic decrease when I operate on my patients and remove their cysts for them. Are there pre-treatments that you can use to improve your IVF outcomes? Well, I hear all the time about people trying things like Lupron. They take Lupron before their IVF cycle. Lupron before an IVF cycle is not the right thing to do. It's actually been proven to be detrimental. So if your doctor is telling you to take Lupron before your IVF cycle, tell them the Cochrane database as of 2019 showed that it is not only not helpful, it's actually detrimental. It reduces the number of eggs you get. It prolongs the amount of exposure to gonadotropins. It prolongs your time that's needed, and it may even reduce the chances of live birth. Do not take Lupron before an IVF cycle. It just doesn't make sense. It should not be done. What about Lupron plus something? Well, we talk about this on our show all the time. Here are 3 separate studies, all clearly indicating almost a doubling of the success rate when you took Lupron and letrozole before your IVF cycle or before your frozen embryo transfer, including all of these in either endo patients or patients with recurrent implantation failures. So there is a very significantly increased chance of success if you mix the Lupron and the letrozole. Why is this? Because you're getting your estrogen levels as low as possible, which reduces the inflammation and gives you the best chance of getting that endometriosis to have a minimal effect on the ability of the embryo to implant. So Lupron plus letrozole, great idea. Lupron alone, useless, don't do it. What about Orilissa? Loads of people now have switched to Orilissa. There is zero evidence, as you can see here from a PubMed search, indicating that Orilissa is of any value in someone that's undergoing IVF. So if you're doing Orilissa, you're doing it on your own and you're hoping that it works. There is absolutely no proof that Orilissa is going to work for you or be beneficial. So we don't use it at all in our practice. There must be something else that works. Well, there is one study and another meta-analysis that showed that if you take Visan, which is called Diagnostic, and is only available, unfortunately, in Canada and Europe, not available in the US, that you can improve your chances. They had a 45% increase in in the implantation rate and almost a doubling of the clinical pregnancy rate and the live birth rate. You have to do it for about 3 months before your IVF cycle. And this was mainly done in patients who are going on to fresh transfers, which I do not advocate for, but it is a reasonable thing to consider if you have access to it. Is there an optimal stimulation protocol? Well, there isn't. There are no studies out there that say Dr. Victory's protocol is better than Dr. XYZ's protocol. And so I can't tell you that there is one study that shows that there is a better protocol out there. However, there are some principles that you should stick with. We know that there is no significant difference between GnRH agonists or antagonists, progesterone priming, the dose that you should use, or anything like that. But we do know that there are some basic principles for all IVF cycles that would still apply to you as an endo patient, if not more so. One, most people these days are using an antagonist cycle. Endometriosis patients don't make as many eggs, they make more immature eggs. Using a long protocol with something like Lupron might give you endometriosis suppression, but it's also going to suppress your ovaries, which is not a great idea. Two, you should use a mixed gonadotropin protocol, which means some urinary to some recombinant product. That has been shown to give you the best outcomes. And so I don't care which company you use, but you want a bit of a mixture and at least some LH to FSH activity. Three, don't go super high dose. If you've got weak ovaries and they're telling you it takes 600 units, you're actually just barbecuing your eggs. That's a terrible idea. Don't do that. Take a reasonable dose of medications. 300, 375. Study we reviewed very recently on our show showed that if you had a high egg production or a low egg production, the best dose was actually just 225 units. So don't overdo it. You're not going to make more eggs. You're just going to kill the ones you already have. And then very important, don't overdo the stimulation. You don't want to go past 12 or 13 days because we know that that negatively impacts the success rates and we'll have a decrease in the egg quality, the embryo quality, and probably the genetics of the embryos. What do we do for our protocol? Well, we have the Victory protocol, which is already available on YouTube. You can check it out right up there. The reality is we use multiple different approaches. Number one, we use Lupron and Letrozole for 3 months prior to your frozen embryo transfer protocol. Number two, we use a lot of natural supplements, NAC, curcumin, resveratrol, ALA, coenzyme Q10, aspirin, which is important because of the blood clotting issues, the preeclampsia issues, the preterm labor, blood flow, inflammation, all of those things. And we want lots of probiotics because there is some suggestion that endometriosis is actually associated with a bacterial infection called Fusobacterium. So we want to fill you up with good bacteria to counteract any negative bacterial association. Two, we don't use estrogen unless we have to. We use super low doses, 1 milligram or 2 milligrams max. Nobody should be getting a traditional HRT protocol if they have endometriosis. It's not going to work well for you, so please don't do that. Three, you need a high dose double progesterone. That's an injectable progesterone like progesterone in oil, as well as vaginal, and you are aiming for high levels. So in Canadian units, some are between 130 and 150, and in American units between 37 to 45. Make sure they are measuring your levels. It does make a difference, okay? It is very important. Get your levels checked. And then finally, you need an immune protocol. We know that endometriosis causes inflammation. You got to suppress that inflammation. So we use intralipids, we use steroids, and there are good studies that have shown a significant increase in success when you use something like rapamycin, which is sirolimus, or its sibling tacrolimus. So we use tacrolimus because it's easier to access and it works very, very well in our endometriosis patients. So make sure you're getting a customized protocol. You cannot and should not be treated like everybody else because you're not everybody else. What are my top 5 dumbest things to do? 1, give Lupron prior to the stimulation. I already told you, it doesn't work. It actually decreases your success. Please don't do that. There are studies that have shown this. You can see it right here. It's going to reduce your chances of success. 2, make sure that you are not estrogen priming. There is no benefit to estrogen priming in patients without endo, and in patients with endo, you're feeding the endometriosis the one thing it wants to grow, estrogen. Don't do that. It makes absolutely no biological sense whatsoever. So don't do estrogen priming if you have endometriosis. It is actually useless. 3, don't use normal dose progesterone. There are good studies that demonstrate that patients with low levels of progesterone have a much lower chance of success. In the one study we're referencing here, you can see a 51% versus a 34% difference in unadjusted live birth rates. And when they adjusted for it, the odds ratio was double. So you had a doubling of the chance of live birth if you had a better progesterone level. So it is very, very important to both use double progesterone and to have your progesterone levels monitored. Number 2, don't use the HRT protocol. There are so many centers literally giving patients 12 milligrams of estrogen a day and then giving them progesterone and then popping in an embryo. You have poured fuel on fire. You have fed the endometriosis more estrogen than it could ever ask for, and then you're trying to get an embryo to stick. How does that make any sense? It literally makes absolutely no sense. No one should be doing that. Nobody should be getting an HRT protocol if they have endometriosis. There are better protocols for that. Letrozole is much more successful, and the study you see here shows that. And then number 1, my all-time pet peeve, make sure that you are not getting a fresh embryo transfer. When is your estrogen level the highest? Your estrogen level is the absolute highest when you're at the end of an IVF cycle where you've made lots of eggs. Your estrogen level is shot through the roof, and now we're going to try and put an embryo in there. Again, just like an HRT protocol, how does that make any sense? Everybody with endo should be getting frozen embryo transfers unless they had a very low estrogen level during their cycle. Otherwise, it just doesn't make any biological sense whatsoever, and nobody should be doing that. You're losing valuable embryos, you're placing your pregnancy at risk, and we know that there was a highly significant increase in miscarriage risks and a higher chance of live birth in the frozen embryos. Nobody should be doing that. So make sure you're not getting that. Overall, what's important? Individualized care is critical. Patients should be getting endometriosis specific protocols. They should be getting for stimulation. They should be getting customized protocols for frozen embryo transfers. Some patients will benefit from surgery, others may not, but it should always be up there for consideration. And immunological testing and therapy can make a huge difference to your outcome. We've seen a greater than 50% increase in clinical pregnancy in patients with something simple like rapamycin, sirolimus. Patients need to know if they need immunological treatments or not. And there's now very good testing available and treatments available which can change your outcome. So make sure you are getting customized care. What are the problems that you face if you have endometriosis? Well, these are all posts that people gave me. Thankfully, I've anonymized them for you, where you can see patients were told that it didn't matter or they got guilted. One patient was told not to use progesterone because it was potentially damaging to her baby. I mean, where do people come up with this stuff from? It's insane. No doctor should be saying that to their patient. And then the RE looked the patient dead in the eyes and said, "You do not have endo." She subsequently had laparoscopic surgery, and what did they find? Endo. So for you to be dismissed is absolutely unacceptable. Nobody should be dismissed. Patients are constantly dismissed for their concerns, even when they know that they have endo. Their REs aren't listening. They're not listening to you about not doing an HRT protocol, about needing your progesterone level checked, about using double progesterone. Patients are facing this battle to get good care, and that is not a fair position to be in. Finally, some patients just can't get the testing that they need. They're either refused the surgery, or they're refused progesterone level checking, or they're refused what they need to find out, including immunological testing, because their REs disagree. So here's my advice to you. If you are in a situation where you can't get the care that you need, ask yourself, why aren't you getting the care that you need? This is an article about one specific institution. It had nothing to do with me whatsoever, and I'm not trying to pick on anybody. I have very good people that work at some of the clinics related to this institution, where they are being driven to produce, because this company is owned by venture capital or private equity, like many other fertility centers are. And the bottom line is the bottom line, which is financial. And they need to make more money so they can be profitable, so they can sell this huge conglomerate to someone bigger. Definitely not ideal, definitely not good for your care. And that doesn't mean the physician taking care of you doesn't care. There's someone I respect tremendously, in fact, several people that work for this company that I respect tremendously, knowledgeable, intelligent, highly skilled, good people, caring, wonderful doctors. But if the overall message being driven is we need to do more IVF, you have to ask yourself, are you getting the right kind of care? So when you ask yourself that question and your answer is, I'm not sure, here's what you do. You run. Because at the end of the day, your money is what is going to drive the care that you get. And if you take your money away from the places that are not providing you with the care you deserve, then they're going to wake up and realize they have to provide you with better care. And there are centers like ours that are able, willing, knowledgeable, and prepared to give you the care that you need, endometriosis specific, patient specific, to get you from A to baby.